Welcome to the OAA Sports Foundation show. I'm Dr. Rob Palumbo from OAA Orthopedic Specialist and Sports Medicine Institute. Today we're really excited because we're going to talk about a new institute that we have at OAA. That institute is one of the OAA Restorative Medicine Institute. It's fresh off the presses, and with me today is my partner, Joel Crosson, who's been a huge part of this. It's been 2 years in the making, I guess, and it's been crazy, but now we really started. We really started as of a couple weeks ago. We really started diving in, but it's something we've kind of been talking about. I think since you were a fellow.
Yes. Yes.
So
6 years ago.
So there's a lot of things that come out when people think about restorative medicine, and one of the big things that come out is PRP and healing bones and healing tendons and all the other things that you hear out there. But what I wanted to do today is really explain what it is, what we do, what we're trying to do, what we've done in the past, and what we're doing now. So
Sure.
why don't we talk about a little bit of the history, how it came about?
Sure. So I think we started, it's been years that OAA has been doing PRP treatments in the office, and PRP stands for platelet-rich plasma, where you have the ability to use your platelets, which are full of good growth factors, to heal poor healing or bad tendons. And so for years we've been doing that, and then we thought there was a little bit of like a void in treatment options that we could provide, and so we've expanded our practice now to include the stem cell, and you would get stem cell treatments from bone marrow, and that has the ability to help regenerate and revitalize cartilage and tendons, and so there's many different aspects where it could be used in the sports medicine realm.
So people, there's a lot of people out there that, they're not biologists. So let's talk about what the stem cell is and where it comes from and let's talk about what the perfect stem cell would be.
Sure.
And let's talk about what we have so far and what we're hoping to get to someday.
Sure. So I think the perfect scenario would be healthy patient, no significant medical issues, who has healthy stem cells, and you can take out those stem cells from parts of their bone. We use the pelvic bone, and they're called mesenchymal stem cells, and you hope that they regrow into whatever area you're putting them into. For example, if it's the knee joint, going to regrow into new cartilage.
So as most people know out there, most of the blood and blood products are developed in the bone marrow, okay? And the bone marrow is that spongy bone within bones. And where it's the most is in the pelvic bone, the big bone between your spine and your legs. And so there are other areas to get these cells as well.
Mm-hmm.
And what you're hoping to do is to get that very basic cell, the most basic
Correct.
cell that doesn't know what it is yet.
Correct.
Okay, so if you take a muscle cell, you're going to grow muscles. If you put that in a petri dish, and you'll grow muscles, and they can do that. They've done it with skin, where they've
Sure.
for burn victims, and those are the things that they've been doing. But what the holy grail would be is an absolute before any cell ever differentiated ever, to get this cell that you could just expose it to an environment and it would become whatever cell is in that environment.
Exactly.
Not exactly there yet, obviously, and that, like I said, that's the holy grail. I've been telling patients for probably the last 10 years, and you've probably heard the speech before, that when I see their arthritis, and they're at that in-between stage where they're young, they're otherwise fairly active.
Sure.
Their knee is starting to get trashed. The arthritis is getting there, but nobody's going to do a total joint on them yet.
Sure.
And then you can't do anything arthroscopically, sticking a scope in and cleaning it, because that usually doesn't work. And you have cortisone injections, okay, which we've done for years,
Yes.
which is an anti-inflammatory, and it does calm the knee down.
Sure.
But once the knee gets inflamed again, it gets inflamed.
It's only a temporary
It's
fix.
a temporary fix. And then it's probably about 15 years now, We've had hyaluronic acid, which is the slippery part of the fluid that comes out of a joint. Right. And we've been able to. First, it was developed actually from the rooster combs. Yes. Okay, and that's why people go, you get the chicken shots. And but now it's actually made biologically, and so it's not from that. And we're having a lot less reactions in the knee when you use that type, and that is, again, it increases the slipperiness in the knee joint. So I always describe when you first start getting arthritis in the knee, it's like a cobblestone street rather than an ice skating ring where you just slide and you're starting to grind. And what the hyaluronic acid does is add that slipperiness. So it could last for 4 to 6 months, and there are some people that have done really well with that. Sure. But that problem with that in-between patient,
sure,
when things weren't started.
They have to come back twice a year, and so it becomes a little
exactly. And not every, and again, with any of these treatments, nobody gets 100% better, and not 100% of the people do well.
Sure.
So then, it's been over the last several years, and obviously it first started in the laboratory and trying to figure things out, and trying to produce these stem cells, or at least find. I guess the right word is find the stem cell, right? So they've gone through fat, try to find them fat, but it seems like right now, either fat or the bone marrow seems to be the right place to find at least the most undifferentiated form of these cells that we can find right now.
Correct, and right now the most ethical and legal way to do it is through the through the bone marrow. The FDA does not allow any manipulation of fat, so you really cannot use any stem cells from the fat tissue.
And what you're talking about is like you just like somebody getting liposuction, you get fat out.
Sure.
And we know that there's some good cells in that and good stem cells in that. However, right now the FDA in the United States does not allow to manipulate or add anything to that to get those stem cells out.
Correct.
Which we think is ridiculous, but that's okay. We won't talk about the FDA on this podcast, but I hate them. So I mean, they're doing it in Europe, and I digress. So basically the place that we get it now is from the bone marrow.
From the bone marrow. And the fat tissue would be used as a scaffolding only.
Right. I want to go back, okay, because we really started before we did it before we did the stem cells, we used what's called platelet-rich plasma, or PRP. And that was really first utilized in the athletic population, where we find a lot of this. Our professional athletes are often the guinea pigs for a lot of these things. And I know that when I started 1,000 years ago, actually about over 25 years ago, we had something called prolotherapy. And the idea with the prolotherapy was just sticking needles in a damaged area of tendon and putting in some caustic fluid, usually sugar water or saline water. And what that would do is cause just this inflammatory process.
Sure.
The good news with inflammatory process, it brings in healing cells. Exactly. So that was the idea.
To try to get the body to heal itself.
Try to get the body to heal itself. Well, then we came up with this PRP. And I'd like you to explain what that PRP is, we'll differentiate that from BMAC or from the bone marrow stem cells.
So PRP stands for platelet-rich plasma. And essentially what it is you're doing a blood draw, just like you would if you were going to get your cholesterol checked or having any type of annual blood work. You would get your blood drawn, it gets spun down in a centrifuge, and then that centrifuge will separate the platelets. The platelets are known for having those good growth factors in them, and so you can use those platelets to help in healing tendons or for low-grade arthritis. I think there's important aspects of PRP to recognize. Not every PRP is the same, and that's part of the issue, right?
Every PRP device to obtain it.
Correct.
It's still from the same, like a blood draw that you would get.
Correct.
When you're giving blood somewhere else.
The blood draw is the same.
Blood draw is the same.
How much you're taking is different, and every centrifuge is different, and that is part of the reason why PRP is still considered experimental, because we cannot get sufficient data to be on the same track.
Right.
We need to be able to compare each study like apples to apples instead of apples to oranges. Right now, there's different centrifuges being used in different studies, and so you have a hard time comparing them. But we have done a better job at realizing that over the past couple years and trying to get more data that looks alike to be able to say, okay, this stuff really works.
And some of the differences we've found in the PRP is actually helpful. I mean, there's some machines made PRP that you had a little bit more white blood cells in it. Correct. Some of them made PRP that had a little bit less white blood. And so that shift, we found out, well, this type of PRP was good for one thing, and this type of PRP was good for another thing. And that's the learning curve we've been under.
Exactly.
That's the learning curve we've been under. But for things like patella tendonitis or jumper's knee and lateral epicondylitis, we've gotten a lot better, and even rotator cuff tendonitis and small tears and those kind of things. We've said, okay, we're getting to know what we could use this for a little bit better.
Sure.
And then we started saying, well, okay, if these growth factors from the platelets are good, what about if we can isolate the stem cells?
Exactly.
And that's where the research continued. First in the animal model, and then started doing it clinically. And I think that's where the big differentiation of what we've kind of figured out, or what's been figured out. And why don't you talk about a little bit about where the device is now, where the one we have at our why we use it.
Sure.
What's the advantage of our type of centrifuge? And it's not just a centrifuge. It's a little bit of a robot almost.
It kind of is. So when we were looking at different centrifuge devices, we decided to go with the Thrax Angel device, and essentially it has the ability to change the hematocrit level. So you can you can say how many platelets you want and at what percentage you want them. So it has a light device that kind of takes in, or like pulls in or pulls out different aspects of our blood products, and so the final product can change based upon what we change on the device, which is helpful to be more specific to whatever you're treating, whether it's more osteoarthritis or whether it is a tendinopathy or that wear and tear in the tendon.
Right. And so that's kind of where we are now. So now I want to talk a little switch about, all right, so we know that for PRP, we would do a blood draw, depending on which device and how much we needed. It would depend on how much blood we'd take out, but never, it's never too much. But now when we're going for the stem cells, when we're going for the precursor cells, the ones that are undifferentiated, that could become other things like cartilage, it's a little bit different. It's a little bit more of a procedure.
Sure.
Why don't we go over it? I mean, and one of the things, again, one of the reasons, again, it's exciting because we opened up procedure rooms just for this. Special tables. We have the devices ready for us, and the other thing that has really changed things. And again, as a orthopedic surgeon, one of the things that I wasn't brought up with was the use of the ultrasound. And the ultrasound, you're lucky because you learned it as you went, and you've taken many courses, and that's something that you've been studying for a while, and you're doing very well with it. Talk about what you could see in the ultrasound, and why it's so much better to use the ultrasound rather than kind of blindly going into where you think the problem is.
Yeah, absolutely. I mean, there's been a ton of studies done in the recent past. There's been a ton of studies done over the recent past that have really shown that you might think you're in the location that you're in, but really you're not. And so ultrasound allows you to have that ability to know. There's no second guessing. You're in the spot that you want to be in, whether it's the knee joint, whether it's in the Achilles, in the bursa area. You have to be very accurate if you're using these types of treatments. I think so. So ultrasound allows us the ability to do that.
And the good thing about ultrasound, I mean, in the past, say you wanted to inject the knee joint for arthritis, you would do it under fluoro, which is X-ray. And X-ray just shows bone or nothing.
Sure.
All right. So you can kind of guess where you are, in the joint or out of the joint. You know where you are between bones. But the difference between the ultrasound, it's not obvious. It's not quite an MRI, which shows you all these differentiations of the soft tissue. It doesn't get as deep as that. But for what you need, you can tell the difference between a tendon, joint, fluid in a joint, vessels, and nerves. Absolutely. So you can really specifically go exactly where you want to go. And I think just that, and again, we started, the learning curve on the PRP helps so much. I mean, I could tell you, the accuracy for which I'm treating a tendonitis problem in the elbow for like tennis elbow or when I'm doing a jumper's knee is I'm exactly where you want to be, and it's so much better. Yeah. So now we have this instrument, ultrasound.
Yeah, I was going to say there's a lot of benefits for ultrasound because it's definitely cost effective. It's much cheaper than MRI, and it might not provide the exact same experience that an MRI can, but you can use it in a dynamic sense. So you can move the joint, whether it's a shoulder or a knee, which really gives you a better
or for us, like for dancers with snapping hip syndrome, those kind of things.
Exactly.
You could actually see it because you're moving it, and you're placing the probe, which is kind of cool because the patient themselves they're watching the monitor as you're doing it.
Sure.
And you can say this is where the problem is, and it doesn't take much to really show them where the pathology is. So that's kind of the cool part about it.
And sometimes that really helps because, like, just recently, for example, I had a patient who had been getting bursa injections into her shoulder, and she has some rotator cuff pathology, but she also has a little bit of mild arthritis in that shoulder, and she wasn't getting better with her bursa injections. So I said, you know what, let's put the ultrasound on. We can do an injection into your joint, and within minutes, she felt better. And so it is very gratifying. I mean, you have that instant gratification of,
and you're
exactly where you are, and that tells you it's not only diagnostic, but it's therapeutic because you've not only helped them and given them pain relief, but now you know where that problem was.
So let's talk a little bit about. We'll talk a little about again what we're talking about again today is the OAA Restorative Medicine Institute, and these are things that we've been doing, but we're really consolidated into one plan, to one idea, because we're going to be able to do the research on it. We're going to be able to do, really follow the patients very closely because we have an outcomes system that we're using that is very state-of-the-art, which I'm very happy about. But what I want to talk about also is, all right, so now we have this patient that comes to you, again, one of your friends, and I hope, young, early 30s, has been an athlete her whole life, trashed her knee through ACLs in the past, and now she's, 3 ACLs, and she's just, each time you get an ACL, you're doing some more damage to the joint. So now here she is, young mother, active, fit, wants to continue to do that.
Sure.
And obviously if you bring her to one of our joint specialists, they're going to go, no way.
No way. She's 33.
And then you bring her to one of me, the surgeons, the sports surgeons, we're going to go, there's really not much we could do for her. Even a clean out isn't going to last. It's not going to help.
Sure.
So we're kind of stuck. And what are you're going to say, well, here, use a cane, don't run, don't do this, don't play with your children. It's just not fair.
It doesn't work.
And so I want to talk a little about what are the expectations, because it's not 100%. When we're talking about the bone marrow or the PRP, I'll talk about the stem cell bone marrow specifically. Where are we in the research? Where are we in what we know from the current studies? Where are we? Where are we? Where are we now?
Sure. So I think the biggest thing right now is it's still early. There's no doubt about that. So there's a lot more research that has to be done, and I will be the first person to admit that. We are trying to add to that. we have asked our patients to participate in surveys, and most of them will agree because they're happy to help with that, and we will follow them. They are completely like de-identified surveys that patients will get, and they start that process prior to treatment, and then we follow them.
De-identified. It's totally, nobody knows who it is.
Anonymous.
They can't.
Yep.
It's anonymous.
There's no names,
we're not gonna.
but we do know that we treated either their knee or their shoulder or their hip, and so we can follow those patients out. And if, for example,
we can put that into the big database.
Sure. And if they started with a pain level, let's say of a 6 on a daily basis, you can follow them at 2 weeks out. What was their pain level? At 4 weeks, at 6 months, at 1 year, at 2 years. And we're trying to follow patients out to make sure that our standard of care is where it needs to be and that we are having success. And if there are cases that aren't successful, what are we missing? We want to make sure we're picking the right patients, and this gives us the opportunity to follow that.
And one of the things that we've done, and I'm proud to say, that we've teamed up with Blue Tail Medicine out of St. Louis.
Sure.
And Dr. David Crane is in the forefront of this. And he and his group have done amazing work following. They're the ones doing the research. The fact that we get to work with their protocols, what we do afterwards, and so we're all studying the same thing. That's what you said at the beginning. Yeah. There were so many different techniques, so many different ways of doing things. There's no one, you can't follow it if it's a bunch of information that means nothing.
Correct. We all need to get onto the same page. And
we're doing it on the same page and with a bigger group of doctors doing it the same way, and we'll be able to tweak it all together.
Exactly.
And the idea is over the next few years is figure out how to do this better and what other things can we do better. But again, let's go back to where we are 2018.
So I think one of the biggest things was when we looked at, how are we going to learn this and how are we going to bring this to our patients? Obviously, the biggest thing is do no harm. We want to make sure that we're doing right by our patients, and we're doing it through our mission and vision as OAA, as a group. And so we wanted to provide something that had the possibility of helping our patients. So that's first and foremost. And safety is the biggest concern, and we want to make sure we're doing it the right way. And so we felt that Blue Tail Group was on the forefront. They are doing research. They are very well published in the literature, and so it's Dr. Dave Crane, Dr. Kristen Oliver, and Dr. Matt Bays, and those guys have really done a great job to really work on and publish their data. And so we've not only partnered with them, but we want to, so we are one of their affiliates. We have been able to train under them, which has been absolutely invaluable.
Correct.
And we also want to collect our data to be able to add to theirs. I mean, they have a database of over 30,000 patients, and so we want to be able to add to their data to follow patients out and be able to publish that to help even more patients.
So let's just say I'm a patient, okay? Because I want people to know out there what they're gonna, what to expect,
Sure.
So all right, so I'm a 45-year-old patient. I'm coming in. I've had 3-4 meniscectomies on my right knee. The knee has become fairly arthritic. I love to play tennis. I love to golf. I want to be able to ski, but it's killing me. I've been to one of the doctors, and they said, well, you're not a candidate for a total joint right now. And I've been to the sports guys, and they say, well, we can't scope it anymore. There's nothing more to do. And so I've been through the cortisone injections every 4 to 6 months, and they're starting to say, well, we really don't want to do that much anymore. Okay, so then I had the lubricant injections, okay, and the hyaluronic acid and the visco supplements, and I've been through that, and it's like, all right,
what else?
What can I do? They're telling me I can't have surgery. I'm too young, but it's affecting my life.
Sure.
It's affecting my
life.
life.
I think that's part of why we looked into training and learning more about the stem cell treatments, is because there are patients out there that are a younger age and can't or won't have knee replacement for a variety of reasons, whether it's based on age, they're a little bit too young, they want to try to hold off for a couple years, any other health issues that they can't undergo anesthesia, for example. So there are a group of patients that I felt like we were missing, that there was a hole, so to speak, in our treatment options. What else can we offer somebody besides just a simple steroid injection or the visco supplementation? And this kind of falls in between some of the more conventional treatments that might not work for a long period of time or might not work as well, and having a total joint replacement.
So, okay, so I'm in your office. So, Doc, so tell me about it. Tell me, what is this? What are my expectations if I try this? What is, does it work?
Sure. So first of all, we want to make sure that we're picking the appropriate patients, right? Like, are you an appropriate patient, and will you be successful? Because of course, we don't want to do it. We don't want to waste your time or money if you're not gonna if it's not gonna be successful. And so what we have found is that about 65 to 85% of people do have positive results, and there's going to be that 10 to 15% of patients that are non-responders.
Okay.
There are a couple factors that play a role in that: morbid obesity, uncontrolled diabetes, or older age, over the age of 85.
Okay.
Because we find our stem cells are not as healthy at that point. And so, of course, we try to be open and honest to patients about that. But we do find that a high majority of people have good success, and that success can come in the form of pain relief, better motion, and just to be able to be more active. And that can last anywhere from 2 years to even our affiliates have found that they have patients that last 9 years. Now, 9 is a bit high. I would say realistically more in, looking at getting you relief for a few years, but I think that's realistic expectations.
And is it something that, okay, say you had good relief for 2-3 years, can you do it again?
Yes, you can.
Okay.
So right now, the FDA does not let us store anything, right? So you cannot store stem cells. So yes, you would have to go through the whole procedure again, but it is something that you can have done. We don't want to do a procedure within about like 3 to 6 months, because we want you to be able to revitalize, regrow those stem cells. Just like if you were donating blood, you wouldn't donate blood every couple weeks. You need time to
reestablish all those cells in
Exactly.
you. And so, again, you're looking for that, not perfect, but optimal patient. It's one that, has the arthritis, has fairly good motion,
Correct.
is not a medical train wreck,
Correct.
okay? Because that's going to affect anything.
Sure.
Obviously, cancers or lymphomas, things that are, are blood related or
cannot-
systemic related,
you
can't do it. And
Exactly.
and like you said, diabetes, because of the hormonal
Sure.
reactions and
Sure.
and
So diabetes or even thyroid issues, you want to just have under good control before
Okay.
you attempt to have one of these
Okay.
procedures.
all right. So let's walk through a procedure. You say I'm going for it, and you go over the risks, benefits for me. What happens the day I come in?
Sure. So we tell people to eat and drink normally. We want you to hydrate prior to, because we are drawing some blood. That morning you will come in, you get your blood drawn. That gets spun down in a centrifuge, so that separates the platelets for the PRP, the platelet-rich plasma. And then we go ahead and under sterile procedure, meaning we clean everything and everything is draped almost like it were to be in the operating room, but it's not. And you numb into the skin and the bone, and then you aspirate or take out the stem cells from the bone marrow. And then you do take out some fat tissue. So you are taking almost like a little mini liposuction procedure where you are using some fat. Now the fat's acting more as a scaffolding, because we cannot manipulate those cells in any way. As you mentioned before, the FDA does not allow you to manipulate any fat tissue. And so
We'll have a whole episode on the FDA, but go ahead.
and so you look at what's called this regenerative triangle, where you're using the fat for scaffolding, the cells from the stem cells, of course, and the platelets that have good growth factors in them, and using all three of those in combination to be able to attack whichever joint you're you're treating, whether it's the shoulder, the knee, or their hip joint, for example, that you would go ahead and put those into different areas within the knee joint. So different people have arthritis, whether it's in all the compartments within the knee, sometimes it's only the medial compartment or the inside compartment, and so you want to attack multiple different areas in the knee. We treat very globally and not just in one area to try to have the best chance of success.
And again, when they come in, it's the procedure's not long, but it takes time.
Sure. There's a lot of downtime.
First of all, they draw the blood, and that's got to get spin. Then they got to be prepped, and I have a model, and so
perfect.
Here's my little spine model. So often, either the person could be lying on their belly or lying on the side, which is kind of the way I've seen you do it.
Sure.
And so this is the pelvis right here. So you're looking at the front, and that's the way it would be. Where we actually go is the back.
Correct.
And this big iliac crest is where that juicy,
great
storage of the cells is. And actually, it's right back in here.
Correct.
We take it's a big needle. We call it a trocar. I mean, it's pretty big, and we numb up the area of the skin. We numb up the some of the soft tissue around it, and then you actually go and kind of burrow into the bone.
You find the area of where you're going through ultrasound, so you can mark your spot, and then you go right into. So what I usually do is I have my patients laying on their side, so as comfortable as possible, pillow between their knees, just to align their spine and make them comfortable. And then, like you said, we numb into this area, and then we go ahead and we put that trocar in there, and we go into a couple different ways to pull the stem cells out.
And then I've seen you get the fat from is here's the hip, and there's always some little bit of
usually we have a little bit in our flank,
bit of deposit,
buttock,
and it's real superficial. Numb it up and just a little trocar and take it out. It's not a cosmetic difference. It's amazing, and what's amazing is I remember doing it as a resident for cancer reasons. You used to do it on the floor, and it was like people say, "Oh, do I get put to sleep for it?" Not really. You really don't. Yeah. I mean, there are some people that you give some happy pills, I understand, too, beforehand.
So we've definitely used Valium, which is a medicine to help people relax a little bit and make them a little bit sleepy. And we, of course, have somebody drive them. They cannot drive if they take Valium. And we really don't want them driving anyway because you're a little bit uncomfortable after the procedure. But people tolerate this fairly well. Obviously, everyone has different pain tolerances, and some people have a little bit more pain, and some people really have no pain at all. But it is important to know that when you're doing this, they do have kind of a little bit of that deep buttock pain, almost like a sciatic type of pain if anyone's ever experienced sciatica. So they do have that pain, and sometimes that could be just at the procedure, or it can last for about 24 hours afterwards, but that should dissipate pretty quickly.
And the key to this, no anti-inflammatories, no Advil, Aleve, anything for...
Yeah, we try to have people stop their anti-inflammatories if they can, or any of their rheumatologic medications if they can, for about a week or two prior to the procedure, and then up to 4 weeks after. Now, if they're just having a bad day and they really need it, fine, go ahead and take one, but for the most part, we'd like them off of it because we feel like that could inhibit the healing process.
So typical knee or hip, which is kind of, I think seems to be the most, knee, hip, and shoulder. Typically, what's the downtime? So, do they have to be on crutches? Do they have to, or can they just be calm it down for a few weeks? What's the normal?
Of course, it depends on their job, but we try to do it at a convenient time for them. So let's say we do it on a Friday. They take that weekend off where they're really not doing much. We want them to move their joint. We do want them to walk on it and ambulate to prevent any possibility of any blood clots or anything like that. But it is going to be stiff and swollen for a period of time. And then they could go back to work on Monday or Tuesday. If they are on their feet all day, they work in a warehouse or construction or something like that, they might need a couple more days of time off just to rest. We tell them that usually they will be stiff and swollen. For that first 24 hours is painful. 2 weeks, they have some soreness, approximately 2 weeks after the procedure. And then anywhere from that 2-week mark, usually around the 4-week mark, up to 3 to 4 months afterwards is where they start to see that improvement.
So what about going back to the gym, how active can somebody be, immediately and as you go forward?
Really as active as they want to be or as they tolerate. The first 24 hours is usually painful, and we do tell them to expect an increase in pain during that time. We expect about 2 weeks or so of soreness and achiness, maybe not necessarily any more so than they have had in the past. But we do want them walking. We do want them moving their joint around, whether we've worked on their knee or their hip or their shoulder. It doesn't matter. We want them walking and moving. If they feel comfortable going back to the gym in a couple of days just to work on their upper body, for example, if we've worked on their knee, that's fine. And then over time, start to increase their walking, start to get on a bike, get the joint moving, get the legs moving, and then slowly progress from there. And when they're ready, start doing some squats and some overall strengthening exercises. And if we find necessary, we'll get them into some physical therapy as well.
This is really exciting. It's like I said, I've been telling patients this day is coming for like years and years, and now the fact that we could actually start offering it to them is exciting and really exciting. And it's not where it's going to be in 5 years, but it's certainly not where it was 2 years ago. The fact that we're, I think, doing it right. We're getting trained by the right people. We are working with groups around the country that we are researching what we're doing and recording. So those that do it early on are going to be helping those that do it later. So I'm really excited, Joe. I think this is going to be, it's an exciting time at OAA, and it's going to be able to help a lot of people, something that we could really offer them. And so for any of you that are interested, if you go to a website at oaaortho.com, if you go to OAA Restorative Medicine Institute,
yes.
Okay.
Under the regenerative category.
Under the regenerative category, you can find more about it. You'll at the end of this video, we'll have some contact information of actually who you can call and how you could schedule this. And even if it's just some questions you may have and you want to make an appointment with either yourself or Dr. Kraftjack, who are really pushing this through at this time. I'm doing a little bit, but certainly not what you guys are doing. To make an appointment with you guys to talk about this, to see if you're a candidate, and if you are, I really hope you're the best, and I think it's going to be really exciting.
Absolutely.
So thanks for joining. This is great, and hopefully we'll be back soon with another chapter of OAA Sports Foundation show. And thank you for joining us. And again, if you have any questions, I'll look for the information after the video. Thank you.